Bert presents a 65-year-old male, bilateral pain into the buttocks and secondary pain into the lumbar, insidious, non-specific, subacute worsening with movement. He has weakness down the legs and an ache in the lumbar, paresthesia bilaterally going down the thighs, pain worsening in the legs more so than the lumbar, relief by sitting or forward bending, aggravated with walking. Diagnosed with osteoarthritis at 60 years old, so 5 years previous to that. Previous treatment has been physio with no change. We came out with, through a thorough history, 3 differential diagnoses of spinal stenosis, disc protrusion, and imminent claudication. You'll see through our testing, battery clustering, why we chose those tests. We're looking at degenerative changes because of his age, and the pain distribution going down to the legs, testing for either central canal stenosis or foraminal claudication on either vascular or neurological structures. That and also the relieved by forward bending, which you'll see with the stoop. This is the stoop test. It tests for intermittent neurogenic claudication. Positive result is pain relieved by forward flexing during walking, negative if pain is not relieved. This is the degenerative triad. It tests for increased pressure and space occupying lesions leading to example of disc herniation. This is a sitting Kemp's test, maximum compression to the intervertebral foramen and challenging the facet joints. Local pain indicates facet, and radiculopathy down the leg indicates neurogenic claudication. This is the flip test. It's testing the sciatic nerve distribution and lumbar pathology. The examiner is looking for pain in either the lumbar or sciatic nerve distribution. This is straight leg raise, increasing provocation test to the sciatic nerve up to 70 degrees. Past 70 degrees, we have sacroiliac joint and lumbar pathology involvement. Straight leg raise, we're looking for pain on contralateral side to the tested leg, which is looking for space occupying lesion and indicating quite a large intervertebral disc herniation. This is a knuckles test. We're looking for nerve root lesions at L2, L3, femoral nerve involved or rec fem. Pain in the lumbar spine indicates nerve roots. Pain in front of the thighs, rec fem. Eli's test, looking for nerve root lesions L2 to L4, femoral nerve involvement and also rec fem. It's a homophesin test looking for unstable spinal segments and neurogenic claudication, reproduction of patients' familial symptoms. This is the slump test, increased tension in the neuromeningeal tract in an increasing progressive manner.
In chiropractic practice, special diagnostic tests are used to help the practitioner diagnose during an orthopaedic physical assessment of a patient. These tests may be performed after the chiropractor has completed the history, observation, and evaluation of movement to determine the specific structure or pathology involved and rule out the ones that are not. Certain diagnostic tests used regularly in practice may strongly suggest a particular disease or condition when they produce positive results. However, they don't necessarily rule out the disease or condition when they produce negative results. According to Wisniak 2019, statistically, the orthopaedic tests increase in validity through the process of clustering, grouping 3 or more tests to assess or diagnose a certain condition. For this reason, a system of grouping or clustering the tests is used, including clinical prediction rules, so that the examiner can determine if the test will give reliable and useful information that could help in the diagnosis and treatment of the patient. To be useful in practice, the clustered diagnostic test must give reliable data, must be valid, accurate to maximize patient outcomes, and should be evaluated on their ability or accuracy to determine which people in the population have the condition or disease and those who do not. The diagnostic tests chosen in clusters for use in chiropractic practice are determined by sensitivity, specificity, and likelihood ratios. Likelihood ratios are based on determining the odds that a condition is present by combining sensitivity and specificity to indicate whether the test will increase or decrease the probability of the patient having the condition. Sensitivity is the ability of a test to identify people who have a particular condition, disease, or dysfunction. Specificity is the ability of a test to identify people who do not. These are the positive reasons for clustering diagnostic tests in chiropractic practice. If the chiropractor is unsure that the patient has a particular condition, then he can use a cluster of tests for exclusion with high sensitivity, making sure the test specificity is equal to or higher than another test testing for the same condition, as this will rule out all the people who do not have the same condition. That is why we use the cluster of DeGeneres triad, well-spread leg raise, Naklas, and Eli's diagnostic tests for exclusion in our spinal stenosis script concordance test. Because according to Vanderwerf, Bujus, and Groen 2006, a test regimen with 3 or more positive tests can be used in early clinical decision-making to reduce the number of unnecessarily minimally invasive diagnostic procedures. In the same way, if the chiropractor is highly suspicious that a certain condition is present, he can use a cluster of tests for confirmation, using tests with higher specificity to rule in the people who have the same condition, making sure the test sensitivity is equal to or higher than another test testing for the same condition. That is why we chose the cluster of stoop, sitting chems, Vectorus, straight leg raise, homophesin, and slump diagnostic tests to rule in the diagnosis of spinal stenosis. Care must be taken when choosing to cluster diagnostic tests in chiropractic practice. The test will always be influenced by both the clinician and the patient during the examination. Every examiner will typically use the test they found to be clinically effective in their own practice. As stated in McGee 2008, the reliability of the assessment may be affected by the cooperation of the patient, which may be influenced by the patient's ability to relax, tolerate pain, describe apprehension, and show sincerity. It may be affected by the skill of the clinician, which may be influenced by experience and his or her ability to relax and confidently do the test. It could also be affected by the calibration of the equipment. Therefore, a cluster of diagnostic tests should be used as part of an overall clinical assessment that includes a detailed history, observation, and the rest of the examination.